This session, we want to talk about primary care and the key levers to advance health equity. Just a few minutes before I introduce our guest, what we would like to do is take a deeper dive into the role. This is an opportunity and the responsibilities of primary care in efforts to achieve health equity. From my perspective as a primary care physician and also as the director of the National Center for Primary Care and the work we do around health equity, I think it's so important that when we think about primary care, we have to build trusted relationships with communities, but also with those on the front line, the health professionals, frontline clinicians, those in public health, those in community-based organizations, et cetera. And the fundamental qualities of primary care, we need good qualities and we need good initiatives that overcome cultural barriers to make sure that we can repair centuries of systemic racism, discrimination, and disenfranchisement that's happened across communities. We know there's strong evidence, and we've been involved in producing strong evidence of the importance of primary care, how it can improve health systems when you build strong primary care foundations, improve outcomes, lower cost of care, and basically just have more equitable outcomes, whether it's dealing with prevention or those chronic diseases that affect our communities. But however, we know the challenges still remains, access to care, the resources that are needed. We talked about earlier from our guests about technology. Technology is there, but it's not everywhere. Mistrust among communities, small practices disappearing, almost disappeared, frankly. The rural areas and also equitable insurance when it comes to Medicaid populations and the uninsured. How do we get everybody into the health system? So the bottom line is transformation in primary care and payment is so important to how we deliver this care, and it's imperative that we have good policy to support these communities. So when the Primary Care Collaborative, the PCC invited us to collaborate on a brief on the issue of primary care and health equity, we knew this partnership could amplify the issues at all levels of the system and engage primary care clinicians, health system decision makers, and policymakers. So it is my pleasure to introduce Ann Griner. She's a colleague, but she's actually been a friend of the NCPC, and we've been in the PCC, I think, for the last maybe 5 or more years. It's really been a value to us, but it's actually been a warm, welcoming environment, and we've had ongoing interactions that have been valuable to us on this side at Morehouse School of Medicine. But Ann Griner is President and Chief Executive Officer of the Primary Care Collaborative, where she leads the PCC's effort to define and implement an advocacy, research, and education-based agenda that furthers comprehensive, team-based, and patient-centered care, patient-centered primary care. So Ann, I could go on, but I want to welcome you and thank you for your leadership and partnership, and want you to introduce and hear your comments about this important report.
Thank you so much, Dr. Mack. It's wonderful to be here today. And I really want to call out our colleagues who worked to produce this report, which, as you noted, we started as an issue brief, and it turned out into a full-fledged report with lots of citations because there's so much to say. And we really do hope that it is becomes a resource for all of you. I want to, in particular, thank Larry McNeely and Noah Westfald from PCC and Megan Douglas from NCPC for producing this report. I'm going to start by just talking a little bit about the organization and about our current work, and then really show how this report and our effort to address inequities, how it all fits together, if you will. So let me briefly go through, and then I know Dr. Mack, you and I have a chance for some conversation at the back end. Many of you may know the Patient Centered Primary Care Collaborative. We're the same organization. We shortened our name up in 2019, and we are known for the promulgation and adoption of the patient-centered medical home. And it really did catch fire. About a third of primary care physicians, according to the AMA, practice in a PCMH. When we introduced this concept, we introduced a set of principles back in 2007, and we updated them in 2017. And we added some important new principles. And they include this focus on the team. The physician-patient relationship is important, but so is the team. We recognize primary care as a team-based sport. The other thing that we added was this whole notion of equitable care. I think between 2007 and 2017, we learned a lot about how care was not being delivered equitably, and that there were a lot of disparities in care. 350 organizations have signed on to these principles, and we invite you to join them if your organization has not yet signed on. We are a multi-stakeholder organization, and we have all different kinds of constituents within that membership, including NCPC, consumer organizations, health plans, employer organizations, specialty societies, both behavioral health and primary care, tech companies, pharmaceutical companies, and what holds them together? It is this strong commitment to primary care as the foundation of a high-performing health system. Our strategic priorities are to really help others in the health system understand how important primary care is as the foundation of our health system, but also to move to that vision of primary care that I showed you earlier, the shared principles. And we believe that in order to move to advanced primary care models like patient-centered medical home and others that embody those shared principles, we really need to change how much we pay and how we pay primary care. And this is an illustration of the dismal job we're doing in terms of our investment in primary care. It's 5 to 7 cents on the dollar. And yet we have, and rightly so, all these expectations for primary care to really help take care of multiple chronic conditions, to help people at the end of life, to address mental health and substance use disorder, to address inequities in care. And yet our expenditures are paltry, and they haven't gone up. In fact, they've been going in the other direction. We've worked hard to explain how we're doing in terms of investment in primary care, and we've put out reports that look at investment in primary care at the state level and across payers, including Medicaid. And I know that NCPC and Morehouse has done work in this area as well. And what we have found is that if you invest more in primary care, those states that do, you have better patient outcomes. These reports have been used by innovators in states across the country to work on reorienting their systems towards primary care. And leading states have now put in place regulations or laws that require health plans to report on their expenditures. And it starts this wonderful dialogue, which is really the bottom, the top line question is, do our expenditures reflect what we want to achieve in the health system? Are we actually putting money towards getting to better health? And generally, states conclude that they're not. And about half the states that are now reporting on primary care spend or are poised to do so have put in place targets to increase expenditures. And these expenditures go into value-based payment models mostly, and oftentimes the legislation says, so that primary care can better connect patients to social services, so primary care can integrate mental health, et cetera. We've working with many other organizations have helped to light some fires across the country at the state level. I call them brush fires, but it's not sufficient. It is important, and we want to build on that, but we really need a national effort to change how we pay and how much we pay. So in March of this year, we launched a new campaign called Better Health Now. And the title of our campaign is really focused on what we want to achieve. And I think that I imagine everyone in this audience wants to achieve better health personally, organizationally, and as a country. And unfortunately, we appear to be going in the wrong direction. We have come up with a set of concordance recommendations. You can find them on our website. And a growing number of organizations, including NCPC, have signed on to those recommendations. They are focused on furthering the payment recommendations in the NASM report. We invite you to read these materials, to sign on to these recommendations, to show your support. If you want to be involved in developing and iterating on the policy to move this agenda forward, we'd also welcome you as a member of the Primary Care Collaborative. What motivated our campaign? Well, I think it's clear to so many of you that we really need to address the inequities in care that we've seen made much worse by COVID. And we also feel like there's a growing consensus across the community to move the NASM payment recommendations and many of the recommendations in the NASM report forward. So we want to take advantage of that. In a nutshell, what these recommendations say is invest in what works, and that's primary care, pay for what we want, better health, and what we also need to do is make sure that our policies don't further exacerbate economic and social barriers and get in the way of better health. This report that Dr. Mack referenced really speaks to all three of those pillars. And when I have prior, in the last year, talking to many folks in the equity space, what I discovered is that while they knew primary care was important, they perhaps didn't have the depth of understanding about how primary care can contribute to addressing inequities. And so I asked the team if they would pulled together this report. And when we thought about who we wanted to partner with, the first name that came to mind was NCPC. We understood that we have a lot to learn in this arena and that we really wanted to work with someone who had been focused on addressing inequities for decades. So we're so excited to be working with Morehouse. So in terms of what's in this report, we do start with a description of what's gone on and how inequities have grown starker in the last couple of years. And I know many of you know this data and you've been hearing about it at this conference, but it is sobering to look at. And I hope that, it is a catalyst for all of you, not to just talk about these inequities, but as a real motivator for putting changes in place. This cannot stand, and we really must address this. Our communities are suffering. And why does primary care matter? Much of this evidence is in the NASM report that I referenced earlier, but let me just tick through a couple of things. Dr. Mack reference to the important trusted relationship that primary care plays as the door to the health system. That's really important. And really, through the pandemic, we saw this as an object lesson. People who were hesitant to get vaccinated told folks in survey after survey that they wanted to talk to their primary care doctor or other clinician before they would make that important decision. We know primary care can also connect people to insurance and to services. There's lots of evidence that where you have more primary care, you're going to increase your life expectancy and decrease your mortality. And given the data that we just looked at, that is absolutely critical. And also, the relationship of primary care to high value services and care experiences. Look for a moment at this chart and you can see how critical primary care is in delivering really important screenings and preventive care, helping people manage their diabetes, giving people a better experience of care, a trusted relationship with a physician, nurse practitioner, or a PA. So really primary care plays a really important role. But as Dr. Mack said, it's not available in all communities. There are, 86 million Americans who are in health professional shortage areas. Many of those are in rural areas. Our Black, Asian, and particularly Latino colleagues are less likely to have a usual source of care, a primary care clinician that they can turn to. So at the practice level, and then we'll talk about the policy level, exactly how can primary care promote equity? And we see innovators across the country doing many of these things, and we applaud them. We just want this innovation to spread so that many more Americans from marginalized and vulnerable communities can benefit from high-performing primary care. So at these leading practices, they're helping patients enroll in Medicaid or in other commercial health plans and connecting them to FQHCs. They are truly integrating medical, mental, and social supports, often leveraging community health workers to help connect patients to the community. And this integration is really central because patients just don't show up with, one issue. There's a complex web of things that need to be addressed. And primary care, when it is properly financed, is well positioned to address people as whole people, not just problem by problem. Also, in many communities, we see where primary care is providing culturally and linguistically appropriate care, and that really does build the relationship. Helping patients leverage digital tools. You heard about that this morning, more and more tools coming into the marketplace. And also in some of the leading practices, incorporating diverse patient voices so that the delivery system is most responsive to the patients that it's serving. And you really need to hear from the patients to understand, how to make changes to the delivery of care to be most responsive to your patients. Also, we do know of practices that are partnering with primary care research-based networks, and we can learn about how to deliver better care by really putting in place research at the practice level that feeds back into our evidence base. So, lovely examples around the country. I know a number of innovators are going to be speaking to all of you today and tomorrow, and already have. We celebrate those innovators, but in order to scale innovation and to really spread these good ideas, we need some very important policy changes. And I invite you to examine our policy recommendations in our report and to join us in advocating for these changes. First, we need to really maintain and grow the safety net. We know that many people in communities don't have access to primary care. And that is both FQHCs, but also, as Dr. Mack referenced earlier, shoring up independent practice. About 30% of physicians, we don't have the same data for other primary care clinicians, are still in independent practices, and that is shrinking. those practices are more likely to serve the safety net. So we don't want them to go away. We want to make sure that the policies we put in place don't further undermine these independent practices. We also really need to beef up our data collection. I come out of the quality world, and I do know that measures can sometimes be burdensome, and there are too many, and we need better measures, but we also need the data collection to inform those measures, and we need to be collecting data related to equity and social needs so that we can understand, are we delivering care that is really equitable across race and ethnicity, or do we have gaps in care? What about people's social needs? We know that only 20% of a patient's outcome is as a result of medical care. So much relates to their social needs, and we need to understand what those social needs are so we can connect patients to social services. Number 3 is really where we do the balance of our work in order to provide whole person care and address, the various needs that patients have. We need a team. We need a village. We don't need a teamlet, a doc and an MA. We need a full-fledged team. And that is only possible if we change not only how we pay, but how much we pay. And so I hope you will join with us in advocating for new payment models to really address these issues. We've had a wonderful experiment the last number of years with telehealth, and we've seen so much fabulous innovation. My hat's off to the primary care clinicians that really innovated so quickly to address their patient needs. But we want to make sure that these flexibilities that have been put in place continue, while at the same time making sure that patients in all communities and have access to broadband so that they can take advantage of telehealth. And finally, as we put these new and important changes in place, we need to monitor and make sure that there are no unintended consequences. So now let me turn it back to Dr. Mack and look forward to this conversation.
Thank you, Ann. And again, thank you for partnering with us on this report and sharing the results. I'd just like to start by asking you a question, Ann, about what do you believe should be, what are the implications of the report, and how do you think it would best serve us as we distribute this to the community?
Well, I think that we need to partner with others to think about what are the actual change practices that need to happen in practices in order to, help them evolve to address these set of issues. And I know the California Healthcare Foundation has just put out a change package, and we look for others that are coming on board. In terms of the policy recommendations, I believe that we need to build a really strong and robust coalition to focus on the payment changes that are needed at the federal level. It's exciting to me that one of our next speakers, Judy Steinberg from HHS, is here today, because I do think that the federal government, working across all the various agencies, can play a really vital role in helping to lift up policies in an integrated and coordinated fashion to strengthen primary care, not only in the payment arena, but in many other areas.
Thank you. Thank you. Well, just a comment, I think we're close to our time. But was there anything else that you wanted to comment on or ask?
Well, I guess one reflection I have, and I would be curious, Dr. Mack, if you see this as well, is that, we've had, a lot of this innovation work go on for decades, in the primary care space. But we haven't perhaps worked as collaboratively as we could across all the different types of primary care, all the different clinicians, bringing in, folks who are working on mental health, maternal mortality issues, the range of issues that primary care can help to address. It's not the silver bullet, but it's a really important component. And so I hope that, the sorts of partnerships that is demonstrated by this collaboration will continue with all different parts of the ecosystem, because the stakeholders that want to keep the status quo are quite powerful, and we need to really form really strong partnerships to move this kind of agenda forward. And it's just so exciting to be working with you. Now let's help move the recommendations in this report forward, so they're not just words on a page, but they actually move into policy in the federal government, at the state level, and in private plans across the country.
Wonderful. And I just want to pull out one thing you said about the independent practices, which is so dear to us. If I think about when I first started practicing the primary care model as a family physician, we could go in the room and spend ample amount of time, and it seemed like, the reimbursement was enough at that time. We know reimbursement is a big, the policies around how conditions are reimbursed is so important. But also, I like to say the new models of care in which family physicians and primary care physicians are going into, especially in larger practices, the time limitation with patients to develop that intimate partnership is really threatened. So I think we have to look at today's model and really creating a model where, within the independent practice, of course, if you reimburse properly, you can kind of make up your own requirements, so to speak. But when you're working for larger practice, that model is threatened. So as we go forward, we need to think about how do we think about the entire model, dealing with the policy, the time requirements, the reimbursement requirements for those practices, to make sure that they have the environment for the patient where they can build that trusted relationship. Because that's what primary care is about. It's about trust and being able to share with that physician, which goes beyond the walls of the clinic.
Yeah. I could not agree more. And I think to patients, understandably, they're not sure why, it takes so long to get in to see primary care. And then once you're in, maybe you don't have the opportunity to really, discuss all the issues you've got. Why is it that I only have, 10 or 15 minutes? And it is these environmental issues that you're speaking to that are really causing these kinds of constraints.
Right.
And yet, the evidence is when you have a payment model that you're incented on population health outcomes and addressing inequities, you're going to actually put more resources into primary care, not less, because what you're incented to do is keep people healthy. And that's not our current incentive system. It's a sick care system. And where the money is in the higher cost specialty and acute care services. And primary care is, a cost center. And that's wrong, because we know that if we move upstream and that if we pay for health, all of a sudden, primary care is going to be at the center of the delivery system, as it should be, and as it is in many European countries and in high-performing health systems in this country. So we know we've seen it, we can touch it, the evidence is there. Now we need to collectively come together, work together to change the reality on the ground. And I'm excited to release this report today with you all, and look forward to our continued collaboration.
Well, thank you, Ann. This is just the start of our work, but we really appreciate the partnership. And I also want to thank Megan and our team for leading up our team with the policy and research and the development, working with you all around this report. Thank you so much. And speaking of Megan, I'm going to turn it over to Megan so she can take us into our next session. Thanks again, Ann.
Thank you.